afternoon, everybody. So we are about to start the prestigious Srimati Rashmoni Mukhopadhyay Memorial Oration. For that, I call upon stage our President, Dr. Bidhan Roy sir. Please, sir, come on the dais. Dr. Utpal Jana sir, immediate past president of AOIWB West Bengal, and Dr. Subhendu Kaur, president-elect AOIWB West Bengal. So today we have with us Dr. Raja Dhar. He will deliver the prestigious Rashmoni Mukhopadhyay Memorial Oration. But last night, Dr. Bimal Kanti Roy, one of our senior member, has passed away. I request Dr. Subhendu Kaur to say a few words, and then we will observe 1 minute silence.
এখানে যারা আছেন আমার মনে হয় ডক্টর বিকে রায়কে সবাই চেনেন। তো কালকে রাত্রিবেলা হঠাৎ আমরা খবর পেলাম যে স্যার খুব হঠাৎ করে সাডেন কার্ডিয়াক অ্যারেস্ট হয়েছেন। তো রাত্রি 10টার সময় উনি গত হয়েছেন। তো আজকে সকালে গিয়ে আমি অ্যাসোসিয়েশনের পক্ষ থেকে ওনাকে মাল্যদান এবং যা যা করার সেগুলো করলাম। কিন্তু সেটা বড় কথা না, ওনার সাথে আমার একটা অদ্ভুত সম্পর্ক ছিল। মানে ডক্টর ডিএন চ্যাটার্জি স্যার, ডক্টর আশিস সিনহা স্যার অ্যান্ড ডক্টর বিকে রায় স্যার এরা সবসময় একসাথে যেতেন কোনো জায়গায় গেলে, এবং আমাকেও তাদের সাথে নিয়ে যেতেন। এবং এই অল্প সময়ের এতে এমন একটা রিলেশন হয়ে গেছিলো, মানে বাড়ির বাবা মা যেমন হয় ওনারাও তেমনি হয়ে গেছিলো। যেখানে যেমন ডক্টর অহিংসা স্যার রয়েছেন, ডক্টর হারাধন বোরা স্যার রয়েছেন, এরাও আমাকে সেইভাবেই স্নেহ করেন। তো যাই হোক, ডক্টর রায়ের এই অকাল বলবো না, ওনার 91 বছর মতো বয়স হয়েছে, কিন্তু সজ্ঞানে একদম উনি গেছেন। ওনার একজন মেয়ে কমলিকা, সেও MBBS ডাক্তার, তারপর পোস্ট গ্রাজুয়েট করেছে প্যাথোলজিতে। তো ডক্টর রায়ের জামাই হচ্ছে আমার ব্যাচমেট নিউরোলজিস্ট। তো বাকি সবই এই ব্যাপারটা সবাই জানেন, এই ব্যাপারে বেশি আর কিছু বলার নেই। একটাই জিনিস শুধু বলি, উনি মেডিকেল কলেজ থেকে MBBS করেছিলেন। ওনার একটা ব্যক্তিগত যে বলি, যেটা উনি সবাইকে বলতেন, মানে উনি বলতেন যে পরিশ্রমের কোনো বিকল্প নাই। কারণ উনি এসেছিলেন বাংলাদেশ থেকে, যখন এখানে এসেছিলেন সেটা উনি গর্ব করে বলতেন, শ্রীরামপুরে একটি বাড়ির গোয়াল ঘরে উনি আশ্রয় নিয়েছিলেন, ওনার ফ্যামিলি শুধু। সেইখান থেকে ওই জায়গায় উনি উঠেছিলেন। হুগলি রিজিয়নে ওনার মতো পেশেন্ট, ওনার মতো একটা সম্মান খুব কম লোকই পেয়েছেন। আমাদের এখানে সিনিয়র স্যারেরা যেমন সম্মান পান কলকাতার, ঠিক সেরকম সম্মান উনি আমাদের ওই রিজিয়নে পেতেন। এবং এই মারা যাওয়ার পরেও যখন লোকে খবর পেয়েছে, প্রচুর লোক সেখানে এসে হাজির হয়েছে। যাই হোক, আর কিছু সেরকম বলার নেই। তা উনি তো আর যারা আছেন ওরাও একটু বলবেন এ ব্যাপারে, আর আমাদের আজকের প্রোগ্রামটার সম্বন্ধেও এনারা বলবেন। ধন্যবাদ।
Dr. Bimal Kanti Roy, AOIWB LM number 30, born on December 28, 1937, died on April 24, 2026. The Association of Otolaryngologists of India, West Bengal, expressed profound grief at the sad demise of our esteemed member, Dr. Bimal Kanti Roy. On 24th April 2026, his loss leaves an irreplaceable void in our association and the medical fraternity. We extend our deepest condolences to his bereaved family. May his soul rest in eternal peace. Please rise for 1 minute silence. Thank you. Before starting the main program, we have with us Mr. Ambrose Rajanpal, the head of business and growth of CK Birla Hospital, CMRI. I call upon stage to felicitate our chairperson, President Sir, with some memento. We thank CMRI and the ENT department, Dr. Arjun Dasgupta, Dr. NVK Mohan, Dr. Chirojit Doctor, and their team for organizing this beautiful event. I request Mr. Ambrose to say a few words.
It's an honor for all of us to have you, respected doctors. It's a great honor for the sales and marketing team from CMRI to have all of you here for this program. And me and Devrati, we always wanted to reach out to the doctors, tell them that if there's any program that we have to organize from our side, we are there to support, to give you 100% in terms of organizing this event. And we are really very proud that, we have the doctors here in CMRI. And in fact, in the previous, programs when Dr. Rajadhar also said the same thing, that we should have more doctors coming to CMRI so that we are able to showcase that what we do here today in Calcutta, in East, is one of the best in the country. So thank you very much, sir.
Now, without further delay, I hand over the mic to our President, Dr. Bidhan Roy, and Dr. Utpal Jana, sir.
Good afternoon, respected seniors, my dear friends, beloved juniors. It's an honor to welcome you to this yearly Rani Rashmoni Mukhopadhyay Memorial Oration, organized by Association of Otolaryngologists of India, West Bengal chapter, at the auditorium of CMRI. Our association is deeply grateful to Dr. Rajadhar for his presence as the orator. The topic is One Airway, the confluence of otolaryngology and respiratory medicine. Rajadhar, MBBS, Calcutta, MD Respiratory Medicine, FRCP, London, MSc, Evidence-Based Medicine, UK, CCT, Respiratory and General Medicine, UK, FCCP, USA, FICS, Indian Chest Society, Diploma in Palliative Care, Newcastle University, Certificate in Education, Teesside University. Director and Academic Director of CK Birla Group of Hospitals, Immediate Past Secretary, Indian Chest Society, Director, Asia Pacific Alliance for Control of Influenza, Head of the Department Pulmonology, CK Group of Hospitals, Kolkata, Founder Member, Southeast Asian Academy of Sleep Medicines, 216 international and national publications in index journals and abstracts, along with 24 book chapters, more than 5,000 citations. Google Scholar, H-Index 31, I-10 Index 65. Chairman, Specialist Committee for Instituting Super Specialty Degree in Respiratory Medicine by the National Board of Education, Government of India. Lead author for bronchiectasis, India Registry. Part of work stream to update WHO Public Health Research Agenda for Influenza. Associate Director for Respirology, Thorax, and Assistant Editor of Lung, India. Dronacharya Award for Excellence in Continuing Medical Education in India. Indira Gandhi Gold Medal for Outstanding Achievement in Medicine. Most welcome, sir.
Welcome, sir. Just I want to say a few words regarding Rashmoni Mukhopadhyay Oration. It was established by our beloved professor S.D. Mukherjee. Probably in the year of 91 or 2, I think Devuda is here. Devuda can tell the exact year. When I was in National Medical College in 93, I joined there in 93. I see that there is a Rashmoni Oration by Amit Ganguly. Probably that was the second or third. So it may be possible that they started in 92 or 91, like that. So it is in the name of our teacher, Professor S.D. Mukherjee's mother, Srimati Rashmoni Mukhopadhyay. Professor S.D. Mukhopadhyay was born in a family in 1932. He was brought up along with his siblings amidst great hardship by his parents. A fact I never forget, particularly his mother, and kept it warm in his heart. He completed his medical graduations from Calcutta National Medical College and went to Lucknow to pursue higher studies. He received his MS ENT degree from King George Medical College and joined in 1962 in the Department of ENT as Deputy Visiting Surgeon. He got promoted to the post of HOD in 1976, where he worked till his retirement in the year 1992. He was a very popular undergraduate and postgraduate teacher, and his affection and relationship with the students was exemplary. He wrote a textbook on otolaryngology. He acted as the editor of Indian Journal of Otolaryngology from 1976 to 81. Rashmoni Mukhopadhyay Memorial Oration was started not in 2005, it is wrongly written here. It is probably in the 1991 or 92. And the orator is, or this time his orator is Dr. Dhar. So the goal was an interdisciplinary exchange of knowledge. Thank you.
Now I request Dr. Bidhan Roy, Dr. Utpal Jana and Dr. Subhendu to hand over the prestigious medal to Dr. Dhar.
So I'm really honored today. My heartfelt thanks to AOI West Bengal and the entire leadership of AOI for having given me this opportunity, given me this honor. It would be amiss of me not to mention one of my closest childhood friends, Dr. Arjun Dasgupta, and also the entire ENT team from CMRI, who are all more than colleagues, family. So the spirit of collaboration, I think, starts with the fact that we are more like family rather than individual doctors and practicing in the same hospital. And so honored to receive the Srimati Rashmoni Mukhopadhyay Memorial Oration. Arjun just told me that this is Dr. S.D. Mukhopadhyay's mother, and I have been taught by Dr. S.D. Mukhopadhyay. I have read his book, and it's an honor today to do an oration in the name of his mother. So this is my quotation. You have to start off by listening to my quotation. What I'll do today in the next 40 odd minutes is to try and engage you in a conversation about one airway. I'll tell you a little bit about my journey in going through the one airway. My area of research interest is actually bronchiectasis, and I will touch on that briefly towards the end of this talk. So this is my experience, and I've put it into a quote. Every patient who walks into my pulmonology clinic with wheezing has already been seen in someone else's clinic, as in the ENT clinic with a blocked nose. The reason we don't know is because we didn't talk to each other when this happened. So this is what I'll do over the next 40 odd minutes. I'll set the scene about the one airway. I'll talk a little bit about our data we have generated in the last 20 years on epidemiology and allergic rhinitis and asthma. We'll talk about the global and the Indian prevalence data. We'll talk about Eastern India and Kolkata, again our data. We'll talk about the United Airway hypothesis and the biological conundrum. And I'll talk a little bit about how allergic rhinitis we have learned over the years progresses to asthma. And I'll give you cohorts, large cohorts European cohorts, albeit cohorts which are robust, which tell you that allergic rhinitis can progress to asthma. We'll talk about shared triggers, we'll talk about the shared inflammation pathway, and we'll talk about diagnosis where ENT and pulmonology overlap with each other. We'll talk about the synergy in management. We'll talk about new drugs, biologics, which prove that it's one airway that we are treating and not two different individual specialties. And we'll talk about biologics in severe disease. And we'll finish off, like I said, by talking about touching on a couple of other disease which has this chain of commonality of one airway, and also how there's a disease continuum between your specialty and ours, and hopefully finish off talking about a vision for the future, joint clinic, joint outcomes, and joint research. So that's what's on the anvil today. So I'll start off by talking about setting the scene and talking about the united airway, the unified airway. So the respiratory tract is one single continuous mucosal structure. Starts here in the nares and goes down up here till the alveoli. And you have the various upper airway structures and the lower airway structures, which all of you know, and it wouldn't warrant my repeating. The epithelium is common. It's two pseudostratified columnar ciliated epithelium. You have a common mucociliary escalator across the airway. You have IgA-mediated mucosal immunity. You have Th2 polarized inflammatory response. And again, all of this is through the entire airway. And this artificial, I called it artificial voluntarily, the artificial subdivision into ENT and pulmonology has created clinical blind spots which neither of us can actually cover. And hence, the concept of one airway, one disease, which was formally articulated in 2001 according to the ARIA guidelines and has grown stronger since. And I will show you how it's grown stronger since. That's the history. So silos to synergy, as in working in your own individual departments, and then working together is silos to synergy. So interestingly, the first time the one airway was envisaged was back in 1947. And even in my training years, which is far after 1947, thankfully, you had extrinsic and intrinsic asthma, which was the first ever phenotyping of asthma that was ever done. In 1991, the WHO ARIA initiative talked about unified airway disease. This was when I had started doing, myself and Arjun, when maybe in our third years doing medicine. And then 2001, the ARIA guidelines got formally proposed as the United Airway Hypothesis. In 2009, there were these large cohort studies, which I'll talk about, which confirmed that allergic rhinitis starts the disease cascade, starts the allergic process, and then moves on to asthma, rather than these being two different dual diseases. In 2019, Jana introduced phenotyping and endotyping as clinical standards. 2022-24, biologics came in, and in my 20 years of doing medicine, respiratory medicine in the UK and Kolkata, I have watched this concept transform from hypothesis to practice. So I've spoken about my practice, my learning. So this is where I did my respiratory medicine. I did my post-graduation. This is the Institute of Postgraduate Medical Education and Research. We did not have this fancy gate at the time. It's been built later. But the department where I worked in, this little block, the chest and cancer block, remains exactly the same as this was. The gentleman in the photographs is one of my mentors, maybe my chief mentor, Professor Alok Gopal Ghoshal. And a lot of what I have learned, not just in the way of medicine, but the way I deal with patients today, has actually come with his blessings. So that's thanks to Claude, who's created a picture of what would be my youthful years. So in 2001, I traveled to the UK. I did an MSc in evidence-based medicine after my travel to the UK. It was not that I was thirsty for research. It was just that I needed to get my CV good enough to try and get a position for a training job. I learned to be curious in the UK. I learned how to ask questions. I learned not to take things for granted, irrespective from where it came. And the starting point was small. I started doing clinical audits. I learned the basic research skills. And again, important, I've put that in highlights again. One of our learnings, and I can see Chiro here, Arjun in the back, I think lots of other people in the audience, we learned how to collaborate across departments. That's a learning that I had in the UK, and they do that very well. And we learned to celebrate small milestones as we went along. So this is the first audit that I did in my life. So I have put this up, and interestingly, it was on the one airway concept. So this was when I was working in Sunderland, and I had just started my registrar training. The 2001 ARIA guidelines had come into being, and this was late 2003, beginning of 2004, where the set standards of 2001 ARIA guidelines were looked at. The standard of care at the time and even today was intranasal corticosteroids for patients across asthma and allergic rhinitis. Anti-allergics were to be used as adjuncts, and inhaled corticosteroids were to be used from the then called BTS Step 2 of asthma. So we collected data across GP practices in Sunderland. The total number of patients was not large. For an audit, it was okay. 186 patients, and these had been quoted in their GP practice as having allergic rhinitis plus asthma. It was a retrospective 12-month review, and we found that 58% of the total number of patients were on intranasal corticosteroid in spite of having a documented diagnosis of allergic rhinitis. The number of patients on inhaled corticosteroids were greater, 87%, 44% were on antihistaminics, 12% had a joint asthma allergic rhinitis plan, 12%. That's a terribly low number. So there was plan to implement change and then re-audit. We worked with the Sunderland Royal Hospital GP Care Initiative, and the re-audit happens to happen towards the end of 2004. These were the initial audit findings, and you can see the gap, a gap of 42% in prescription of intranasal corticosteroids existed. And then you see the allergic rhinitis asthma diagnosis, where a gap of 75% were identified. This was the re-audit result. And what did we do before re-auditing? We did educational sessions for GP on the one airway concept, a couple of them across 1 year at Sunderland Royal. Intranasal corticosteroid alert appeared on the practice computers where the GPs practiced. So it would flag up as intranasal corticosteroids have not been given, even though the patient has a diagnosis of allergic rhinitis. The dual allergic rhinitis asthma coding would ensure that the drugs mandated, the intranasal corticosteroid, the inhaled corticosteroid, would be flagged up. Integrated airway plan became a part and parcel of the GP practice. So the 2004 results were not perfect, but they were far better. A 21% increase in intranasal corticosteroid prescription, antihistaminic prescriptions went up by 23%. Inhaled corticosteroids were very good anyway, got better, and the integrated airway plan had the largest growth at 25%. So the reason I present this data is we have also moved on from here, but I think ways of remembering that this is one airway, treating the one airway concept becomes very important in these individuals, and that's why I have mentioned it. So why this topic? This topic was given to me again by Arjun. Why this oration and why now? So we have 13% of the global burden of asthma. This is our data from the global burden of disease data. This equates to 34 to 36 million asthmatics. Where we are disastrous is asthma deaths. 45% of asthma deaths happen in India. So 45 out of 100 deaths from asthma happen in our country. Allergic rhinitis affects 20 to 30% of the adult Indian population. So I'm specifically speaking about adults here. So think of 110 crores, 20 to 30% of that, which would be more than 30 crores, have allergic rhinitis, and most of them would have diagnosed or undiagnosed common chronic disease, chronic airway disease. Yet ENT and pulmonology clinics function independently at every Indian hospital. And why blame India? I think this is true for almost throughout the world. Eastern India has unique environmental triggers: monsoon humidity, biomass burning, aspergillus sensitization, and I'll speak about each of these individually. Our data in Kolkata, and I'll show them to you, shows that allergic rhinitis is the commonest comorbidity, occurring in more than 80% of cases in uncontrolled asthma. More than 80% of patients have allergic rhinitis, and it's the commonest comorbidity. Hence, the talk today, and going forward is a call to redesign how we think, train, and practice treatment of the airways, treatment of allergic rhinitis and asthma. So let me talk about epidemiology and talk about global numbers and Indian reality. These are global numbers. 300 million people in the world have asthma. 500 million people in the world have allergic rhinitis. There are 250,000 deaths that happen per year globally, even today. So this is data from 2020. So that's 6 years ago. I would suspect the numbers still remain the same, or more or less the same. And 5 to 10% of severe asthma is the proportion of severe asthma worldwide. So 1 out of 10 or 1 out of 20 individuals would have guideline-defined severe asthma. I said 13% of the global population of asthma is in our country. That translates into 36 million. The next figure is the disastrous one. 45% global deaths originate in India. Our mortality is 3 times that of the global mortality. Our morbidity is twice of that of the global mortality, and that would be measured as far as DALYs are concerned. This is something that we published this year as a research letter, and the reason I have put it up is because the numbers I have shown you are probably the tip of the iceberg. I say probably because we don't have data. And how do you translate into greater diagnosis? This is a survey questionnaire which is based out of primary care for GPs to diagnose obstructive airways disease and allergic disease of the airway. So I won't read through this. This is available in Lung India. We published this in March, April. So it's the last edition of Lung India, which is freely available online. However, look at the parameters through which you score these patients. You look at a family history of allergy. You look at nature of symptoms. You look at allergic rhinitis score. You look at smoking status and the number of years that you've smoked. You look at biomass exposure, the number of hours of biomass exposure, and the number of years of biomass exposure are on there, and you score them, and you come up with a score which increases your probability of diagnosis of airways disease. You note I'm saying airways disease consciously rather than talking about asthma or COPD. The screening tool is valid for airways disease. It's not really valid for trying to distinguish between asthma and COPD. The allergic rhinitis is probably the biggest overlooked epidemic in this country. I said the prevalence is about 1 in 3 of the general population in India. In the COVID years, we did a survey where we looked at allergic rhinitis in the healthcare workers. So amongst us, unselected population of healthcare workers in India, we looked at 20,000 healthcare workers. So this is not doctors, just not doctors. There's nurses, there's technicians, therapists, administrators, etc. And we found that 62.5, so 2 out of 3 individuals, us, have allergic rhinitis. What about the urban-rural split? We thought that the number of people with allergic rhinitis in urban areas because of air pollution, etc., would be far higher as compared to what it is in the rural areas. That's wrong. So urban allergic rhinitis happens due to pollution and house dust mite. Rural is due to biomass and seasonal allergens, and the numbers are more or less similar to each other. Dust and air pollution trigger asthma in 50% of our patients. Sensitization, so house dust mite is the greatest in India. Not put that data up, but house mite dust is something which is prevalent in coastal areas, in humid areas of eastern India, and this is the most prevalent trigger for both allergic rhinitis and asthma in our country. Aspergillus sensitization is higher in India as compared to China. China has very high aspergillus sensitization. That's why the comparison. So about 10% aspergillus sensitization in India. Compare that with 2% in China. Winter and monsoon months see a peak of allergic rhinitis and asthma exacerbation, something that we have reported, spoken about repeatedly. Why do we need to mention this? We need to be aware about treatment during this time more than other times of the year. This is where you get flare-ups, exacerbations, and hospitalizations. So I speak about this Delhi study. It came out of the All India Institute of Medical Sciences. I wrote up the paper. I haven't contributed to the patients in this study, but these are northern Indian patients with uncontrolled asthma. And these are fascinating numbers, small sample size, but fascinating numbers. allergic rhinitis was a common comorbidity in about 45% of patients. So note, I said Eastern India, the concurrence of asthma and allergic rhinitis is 80%. Hence, in the north, you get less allergic rhinitis as compared to what you do in the eastern part of the country. Rhinosinusitis is present in 2.5%, but that's likely to be a severe underdiagnosis. And 83.75% of difficult asthma, T2 high asthma, eosinophilic asthma in this study had the same endotype as what drives allergic rhinitis in these individuals. Our study, probably one of the biggest, and I'll keep alluding to this study as we go along, the AP-AIM study, that's the Asia Pacific Asthma Insights into Management study. 70% of asthmatics, 70% in this country, still use oral medications and controllers. Many have been seen just by GPs and not by specialists. Our severe asthma prevalence study showed that spirometry-defined severe asthma was about 10%, which is not very different to what the global literature shows. And my experience, our experience working together in my team and along with our ENT team is that every new patient with asthma needs to be screened for allergic rhinitis, rhinosinusitis, and nasal polyposis. But we are still far away from this, and a lot of the fault lies with me and our team. Going forward, this is something that we need to rectify. So I'll talk about the biologic continuum between United Airways and talk about the United Airways hypothesis. So upper and lower air respiratory tract cover a common mucosal immune network. That's called the MALT network. The T2 inflammation, the Th2 polarized inflammation, is something which drives both diseases, the allergic rhinitis and asthma. And the reasons I've put this interleukins up is because we'll talk about management and biologics later on, where these will come back again. So IL-4 is a class which helps to switch to IgE and goblet cell hyperplasia and hence mucus production. IL-5 causes eosinophil production and increases the survival of eosinophils. So eosinophil destruction is reduced by IL-5. IL-13 causes the airways to become twitchy. The airways are hyperresponsive and there's increased mucus hypersecretion. Interleukin 33 is present on damaged epithelium, and this damaged epithelium is both in the upper airway, the nasal epithelium, and the lower airway. Both have interleukin 3 and TSLP as a part of the damaged epithelium, which drives the chemicals which cause bronchoconstriction. Systemic eosinophilia and elevated Ig are a part of both these diseases. Inhaled allergens cause nasal sensitization. This drives T2 inflammation, and this results in bronchial inflammation, and this is important. So inhaled allergen causes nasal sensitization. This results in Th2 priming. This results in bronchial inflammation, which is why, think about it, allergic rhinitis moves on to asthma over the years. And this is what we have spoken about on this slide, the mechanism of connecting the upper and lower airways. So you have the direct anatomical pathways. Nasal secretions drip down into the larynx, then into the trachea. There's mouth breathing because the nose feels stuffy, because the nose feels blocked. And you have cold, dry, unfiltered air which goes in through the mouth and causes bronchospasm. There's the nasobronchial reflex all of you know about, which causes mucosal stimulation. It causes vagus nerve stimulation. There's secretion of chemokines like interleukin 5 and interleukin 13 from the nasal mucosa after it enters into the circulation. This bone marrow priming, the eosinophils get released into the upper airway and the alarm signals go off. So that's the anatomical pathway. The systemic and immunological connection is nasal polyposis, causes sinus inflammation. And important, sinus inflammation sometimes, in 10% of cases, results in fungal sensitization, and invariably this combination would lead to severe asthma. All of you know there's a correlation between severe asthma and obstructive sleep apnea, which goes beyond obesity. There's nasal obstruction, which is more in patients with OSA. They are mouth breathers. The mouth breathing drives airway inflammation, like I said, and you have airway inflammation when the patient is in bed at night. So that's one of the reasons why uncorrected OSA results in increased airway inflammation and poor control of asthma. You have aspergillus sinusitis and ABPA, and that's the sinus lung fungal highway. And then there's the nasal microbiome, which alters the tone of the lower airway and the immune tone of the lower airway. That's the biological threat. That's probably the language we understand. You have someone with T2 high asthma. You have increased eosinophils in them. You have an exhaled nitric oxide, which is high. Clinically, this is the asthma. Those are the numbers which you would call clinically allergy-driven asthma. Again, going back to the AIM study, so T2 high prevalence asthma in the northern Indian population was 83%. The T2 low asthma was about 16 to 17%. So in our population, unlike the West, you have about a 5-time greater number of T2 high asthma as compared to T2 low asthma, and the numbers for allergic rhinitis probably would be no different. All patients with T2 high asthma should be screened, as we said before, for chronic rhinosinusitis and nasal polyposis. And more so today, because the biologics that you prescribe in these individuals would be dictated as to whether these patients have chronic rhinosinusitis or nasal polyps. They should be looked for atopic dermatitis. You would look for aspergillus sensitization. So do an aspergillus IgE in your patients when you're looking for fungal sinusitis, when you're looking for fungal triggers for asthma. This is not a pulmonologist problem alone. It's not an ENT problem alone. It's a shared challenge, and that's why we are doing this talk today. The mean total Ig in our severe asthma cohort was high. It was 585. So that's the 160 patients we are talking about. A mean IgE of 585, a mean eosinophil count, which is higher than the rest of the country in this study at 390 cells per microliter. So those are the mean numbers from this study. We come to something I've spoken about already, so I'll do it briefly, the aspergillus sinus lung connection in eastern India. So ABPA in India, we have said is 7 to 20% of asthmatics sensitized to aspergillus. In the Delhi study, the numbers were much higher. We know aspergillus sensitization in the north of the country is far greater than anywhere else in the country. Aspergillus sinusitis precedes ABPA. Important point. So if you managed to diagnose a patient with aspergillus sinusitis, you might be able to prevent the onset of ABPA in these individuals. And unilateral opacification CT sinuses, you all well know but better than I do, is the first clue of aspergillus sinusitis. Eastern India, the hot, humid climate, monsoon conditions support aspergillus purulation. You have aspergillus-specific Ig, which is found in a third of uncontrolled asthma cohort. And ENT evaluation, including a nasal endoscopy, CT of the sinuses, is mandatory in all cases with difficult asthma. So important message, never label an asthma as being difficult without first ruling out aspergillus sinus disease. I'll repeat this, it's important for as much for us as it is for you, that never label an asthma as being difficult without ruling out aspergillus sinus disease. So the next section I talk about is allergic rhinitis and asthma and the epidemiological evidence. So the atopic march describes natural history of allergic disease, and this is something you all know. Atopic dermatitis in the first 2 years of life. A small percentage of the Indian population would have food allergy, which comes in next if it happens at all. Then you have allergic rhinitis, and then you go on to have asthma. Not all children progress. Risk factors are a high Ig initially, early sensitization to aeroallergens, parental atopy, urban residence. All of these seem to drive the risk for developing asthma from allergic rhinitis. And there's various cohorts that I have talked about. I'll only talk about the ISAC study, which is our study. Asthma prevalence correlated with allergic rhinitis prevalence in all Indian regions studied across the ISAC phase 3 study, which is the largest allergic rhinitis asthma study we have managed to do in this country. And an ENT doctor who treats a child's allergic rhinitis today, so all of you treating a child with allergic rhinitis today are preventing tomorrow's adult asthma. So that's what we are doing when you're treating allergic rhinitis in your patients today. So come back to my story again. And this is again thanks to AI and Claude. So my ambition when I came back in 2009 was to try and implement some of the clinical research and academic skills that I had learned in the UK. The aim was to try and work by building teams, and I keep repeating this. Try and build collaborative research, clinical medicine, work with academic and non-academic institutes, and build up registry, some of which I have managed and some of which I have not, over the last 15 odd years when I've worked here. After coming back to India, the reason I told you about my coming back to India was, again, like in the UK, the first study I got published after coming back was this study, which came out of the National Allergy Asthma Bronchitis Institute, which Professor Ghoshal, who I mentioned was my mentor, he had established this. So I came back and I started looking at data across 2 years. And we found the most important headline of the study, that 88% of adult asthma patients in the eastern part of the country, and this was a large cohort of 6,000 patients, we found that 88% of adult asthma patients have a childhood history of allergic cold. And this is a study which is quoted, even though it's single center, this is quoted across the board in saying that in India, especially in the eastern part of the country, allergic rhinitis precedes asthma in almost all cases. And this is an important message for all of us. Aggressive treatment of AR in our part of the country will prevent these patients from going on to asthma in a large number of cases. The Indian data gap is we lack long-term atopic March cohort data from our part of the country. What we need, and I'll keep talking about this again, ENT Pulmonology Collaborative Registry to capture the progression of disease. I'll come back to research proposals in a bit. I'll quote this study. This is the study all of you know. This is the Copenhagen allergy study. This looked at a large Scandinavian cohort. And they started off with children of the age of 6 years. And they followed up these children for a period of 20 to 25 years. So 6 years of age, mostly followed them up till 30 years of age and tried to identify the atopic march and the unified airway disease. So population-based Scandinavian cohort, this was not a large cohort, it was about 150, but look at the magnitude of the study. It was a study which spanned over probably 3 decades. So children with allergic rhinitis and those with a family history of asthma or atopy were the population of patients chosen. Longitudinal follow-up was done in these individuals, and the outcomes looked at was asthma development, persistence of allergic rhinitis, and IG sensitization. So development of asthma from allergic rhinitis, especially when there's a family history, persistence of allergic rhinitis, and IG sensitization in these individuals. And interestingly, 30% developed asthma by the time they reached adulthood, which was 18 years of age. So 1/3 of this population, which never had asthma in childhood, just had allergic rhinitis. 1/3 of them developed asthma by the age of 18. 70 to 75% had persistent rhinitis. IG sensitization was the most important risk factor. So early IG sensitization before the age of 10 was the most important risk factor. And family history amplified risks and reduced remission. So if you had a family history, you had 3 times the risk of developing asthma as compared to someone who did not have a family history of asthma. And these are important numbers for all of us to remember. So the atopic march was early atopy with or without eczema, allergic rhinitis by the age of 6, asthma by the age of 18, and then this supported the one airway, one disease. And if there's one study you need to remember by name, that's the Copenhagen study, because that's what unites us, the ENT community with the pulmonology community, and there's good proof via this wonderful study. So important clinical implications from the Copenhagen study, the fact that allergic rhinitis is not a benign disease. It identifies patients with a high risk of asthma. Early diagnosis and active management in this group that you've identified is important. Monitor these children and make sure you take a detailed family history in these individuals, because you can identify a higher risk of asthma in the population which has a positive family history, and integrated upper and lower airway care is of paramount importance. I'll go through this slide in detail, but then I'll skip a few and move forward because I think we are sort of at 3:30 and I need to finish in 10 minutes. But these are predictors of patients who would progress from having allergic rhinitis to asthma. So early onset of allergic rhinitis before the age of 5, perennial allergic rhinitis as opposed to seasonal allergic rhinitis, multiple sensitization to allergens more than 2, an IG of more than 200, a blood eosinophil count of more than 300, nasal polyposis with chronic rhinosinusitis, aspergillus sensitization, atopic dermatitis as a comorbidity, and family history of asthma are important. Important for all of us the ENT doctors, and for the pulmonologists to remember these patient level risk factors, because understand you would be identifying these patients who move on to asthma later, to severe asthma later in childhood, as opposed to waiting till adulthood. The environmental risk factors are, however, more common sense: urban residence, high pollution, tobacco smoke, recurrent respiratory infections in childhood, obesity, poor adherence to allergic rhinitis treatment, oral rather than intranasal steroid use, biomass exposure, poorly ventilated housing, and GRD are the important comorbidities. This is interesting. This is not something I do. One of my colleagues in CMRI, Dr. Beauty Bishas, does this. But this is a proof of concept that it is one disease. This is allergen immunotherapy. So sublingual and subcutaneous allergen immunotherapy reduces the risk of new onset asthma, but as much as 30 to 50%. So that's the PAT study that's been quoted. 3 years of allergen immunotherapy in allergic rhinitis children resulted in a 50% reduction in asthma over a 10-year follow-up period. Fascinating results. If that does not excite you, what will? So 3-year study on allergen immunotherapy in allergic rhinitis children resulted in a 50% reduction in asthma over a 10-year follow-up. Intranasal corticosteroids work well. We showed that in the APAIM study. An important message for all of us, especially for all of you: every allergic rhinitis patient you treat has the potential of developing asthma going forward. This is the study. If this area interests you, excites you, I would ask you to, this is the largest Indian study that's ever been done on looking at the epidemiology of patients in the Asia Pacific region and in India with the combination of asthma and allergic rhinitis. It's called the APAIM study. It's freely available online, so do have a look. So shared triggers is my next topic, and important to say that this, I have outlined it as an Eastern Indian problem. This is no as much a Northern Indian problem as a Southern Indian problem, as a Western and Eastern India problem. We found that dust and air pollution were triggers for asthma in the largest percentage of Indian patients at 50%. The fact that PM 2.5 and ozone, so PM 2.5 and ozone caused the most amount of upper and lower airway inflammation, with the TH2 polarization in the upper and in the lower airway. You look at nasal secretions and you look at eosinophils in the nasal secretion, and you do a induced sputum and you look at the sputum and you find eosinophils in similar numbers in the nasal secretion as well as in the induced sputum. Burning of incense sticks is an important problem. It's not just a public health issue, it's something that we deal with on a day-to-day basis. And I have said that house dust mite and cockroach allergens are the most important in the eastern part. HDM, house dust mite, is the most important trigger in all of India. And then pollen allergy is lesser as compared to the West, but still there. Our number of food triggers, thankfully, is lesser as compared to the West. Come to the next section, which is talking about our overlap, which I've talked about at length. I'll just outline a couple of points and then move on to the next section. So 82% of patients with early symptoms and 70% of severe asthmatics are underdiagnosed. I spoke about tip of the iceberg. Those are the numbers. Remember, we have quoted 35 million as the number of asthmatics in this country. And then we are saying 82% of patients with early symptoms and 70% with severe asthma are clinically undiagnosed. 72% are on oral anti-asthmatic medications. Only about 15% have spirometry, which is thought to be the gold standard for the diagnosis of asthma. We call it by different names because we don't want to call it asthma. We call it shwas, we call it dama, we call it sardi, we call it buker moddhe shai shai korche, but we do not call it asthma because there's such a stigma associated with this disease. You see patients who have allergic rhinitis but undiagnosed asthma. I see patients who have asthma with undiagnosed chronic rhinosinusitis with nasal polyposis. Hence, proposing in front of everyone today that every patient of asthma, difficult asthma, should have a nasal endoscopy, should have a spirometry if they come with allergic rhinitis, and ideal and exhaled nitric oxide, and every patient of both should have an IG and an absolute eosinophil count when they come in, and we should keep data for this. The diagnostic gap costs lives. We have said 45% of global deaths for asthma is in our country, and this is entirely fixable. The toolkit I have spoken about is shared. The pulmonologist and ENT toolkit is there. I won't read through this slide, but important to talk about spirometry, pheno, blood eosinophils, IG from a pulmonologist toolkit. And from your toolkit, which you know better than I do, it's anterior rhinoscopy and nasal endoscopy, the CT of the sinus, the skin prick testing, the exhaled nitric oxide, and then looking for sleep apnea and aspergillus is what is important in the ENT's toolkit. I'll miss a couple of slides and go forward. A typical Kolkata patient with allergic rhinitis, and this is hard data, this is not me making it up, something that we have published. So a typical Kolkata patient with allergic rhinitis and asthma, over 5 years sees a pharmacist and takes oral antihistaminics for rhinitis without an assessment. Sees a GP who gives them antibiotics for a supposed chest infection. Sees an ENT who treats the allergic rhinitis but does not ask about chest symptoms. Sees a pulmonologist who treats the asthma but does not examine the nose. Goes to the emergency department with acute exacerbation after years of suboptimal treatment. And again, quoting the AP-AIM study, 49% of patients with asthma have 3 to 10 exacerbations per year. I'll repeat that. 49% of patients, 1 out of 2 patients would have 3 to 10 exacerbations per year, a poor asthma control score, and a poor allergic rhinitis score if the study had done one. The journey needs to be disrupted, and we need integration of models, which is what we are speaking about today. So the next bit is about synergy, the fact that the world is moving towards synergy. Jana, which is our guidance, ARIA, which is your guidance, talks about joint assessment. It talks about united airways disease. It talks about united assessments and united treatment. So Jana talks about inhaled corticosteroid and formoterol in the maintenance treatment. The Jana ARIA paper talks about asking clinicians not to forget the other end of the airway. In India, the reality is about a third of patients use inhalers in the first place. Remember, 70% of patients are on oral asthma medications. A third of patients would use inhalers. There's a long way to go, but I think there is light at the end of the tunnel. We have got better over the last 10 years. This is the integrated pharmacotherapy on which I'll not spend time. The lower airway, as you know, is managed with a combination of ICS and LABA. The upper airway, you know much better than I do, is an intranasal corticosteroids along with antihistaminics. And then there are the investigations that we spoke about. Talk about biologics briefly, and the world has changed since the discovery of dupilumab, approved for severe asthma and chronic rhinosinusitis. This is the only biologic that's been licensed till date which spans both diseases. So it's approved for severe asthma, it's approved for chronic rhinosinusitis. It will be available in the country by the end of this year, 2026. Probably October, November launch is what we are looking at. Omalizumab is approved for asthma and chronic urticaria. Mepolizumab targets eosinophilic asthma, and there are phase 3 studies being done for chronic rhinosinusitis. Tezepelumab, unfortunately, less said the better, probably won't get a launch in India in the next 5 years. But there are drugs which target both airways, which proves that this is one common airway that we are treating. So this is the add-on therapy eligibility for a study that we did with the All India Institute of Medical Sciences, which we have quoted before. So you have about 12% of patients for omalizumab in this study. You have a fourth of patients for any of the drugs. You have omalizumab plus IL-5 overlap for about 20%, and another 20% for thermoplasty. So you have severe patients, and there are treatments eligible. The bronchial thermoplasty is an age-old phenomenon which no longer happens. However, this was how it was 7 years ago when we published this study. And I have spoken about dupilumab, the united airway biologic, which targets interleukin-4 receptor alpha and also targets the interleukin-13 receptors. And there's good data that it works with the upper part of the airway and as well as the lower part of the airway. So what's the vision? What is preventing integration today is the first question. It's structural. It's separate outpatients department. There's no shared clinics in most Indian hospitals. Education, the medical curriculum trains ENT and pulmonology students separately with absolutely no cross-training. The culture is this patient is not mine, or in some cases, this patient is mine. So there's no referral, there's no handing off, there's no spirit of collaboration. We run busy outpatients clinic. Doing an interspecialty discussion probably is not thought to be merit because there's no time that anyone has. Financially, we work in hospitals. at least I work in hospitals where there's fee-for-service models which incentivize independent care over team-based care, and there's still a guideline gap. Some of it, again, I take ownership for. Our Indian asthma guidelines have not been updated for a while, and the fact that our guidelines do not talk about the common airway, which is something we need to correct soon. And patient awareness, they should know that the nose and the lung are connected with each other, and one problem merits addressing the other is something that we need to integrate. So that's the proposed integrated united airway clinic model. One appointment to see both the ENT and the pulmonologist together, shared electronic records, come up with joint protocols, come up with joint biologic selection meetings, talk about allergic immunotherapy in coordinated manner, talk about joint patient education. The model exists in some of the leading centers globally. Mark my words, I said some of the centers, a small number. It's time for us to get together in Eastern India and build one in this hospital, others, but we need to come together, join hands if we want to see better treatment. And reforming treatment is a joint responsibility. I've put in suggestions here. The slide will be with you. I won't go through it in detail because I don't have time, but training, the new generation needs to learn its one airway in spirit, not just in letter, not just by means of the ARIA guidelines. We need to train our postgraduate trainees. They need to do a rotation in ENT and vice versa. Our national guidelines need to say in the same tone as I'm speaking today for this oration. This is what each specialty brings to the table. What the pulmonologist contributes is expert lower airway phenotyping and endotyping. The investigations we spoke about, the step-up asthma treatment and the single inhaler triple therapy and the biologics. The ENT covers the upper airway diagnosis, the nasal endoscopy, the sinus CT, the allergy testing, the FES that you guys do so well, the allergen immunotherapy initiation, the insomnia rehabilitation are things that the ENT would bring to the table. The challenges in asthma and allergic rhinitis is similar. This is something that I'm very proud of. We published this in our Asia Pacific journal, Respirology, now about 5 years ago, where we had all of Asia getting together to write up these challenges faced in managing adult asthma. And we looked at different challenges. I won't go through into this. I don't have time. Probably not relevant for this talk either. But important to address stigma. Stigma about asthma being a taboo disease. Girls not getting married because they have asthma. Lowering treatment goals. So the patient expectations are low. The treatment hence you deliver is of a lower quality. Suboptimal clinical practices with inappropriate prescription of oral agents rather than inhaled agents. Access to biologic medications is all about finances, not about who needs it. There's variability in access to specialized care. All of this are not problems just with asthma. In some way or the other are problems that you need to address in patients with allergic rhinitis. And I said I would speak about research agenda. I've put a list up there. I know all of this is in my pipe dreams. All of this is never going to happen. But some of it, longitudinal atopic cohort, is something we can start tomorrow. If there are 10 centers in this city who would join hands in tracking allergic rhinitis children from ENT clinics and our clinics to asthma outcomes at 10 years, you have wonderful data like what you found with the Copenhagen data. The Aspergillus sinusitis ABP registry is something that we can do easily. Just keeping data, you need a sinus CT. Biologic real-world outcome studies looking at Utpal when it becomes available in this year. Looking at air quality and airway disease is something we are doing just now. So that's something we are addressing just now. Inhaler technique audits, health economic studies, policy revamping, all of it, our research agenda. I've said Eastern India. I'm sure it's true for the rest of the country too. So I'll skip that and finish off by showing you that it's not just about asthma. So I said my research interest is in bronchiectasis. I had a bad accident about 1.5 years ago and lots of good wishes from friends, support from friends, a lot of whom are sitting in the audience today. I survived when I had absolutely no chance of surviving. I'll tell you why I put this slide up today. So when I recovered in the beginning of January 2025, I did not know how long a life I would have. And one of the things that was on the agenda was to try and generate research data in this country and collaborate. And again, I show this not to boast. I have never learned how to do research, even though I did an MSc in evidence-based medicine. However, see how the graph has gone up. The tallest building there is 2025. That's the year where I had almost died and come back to life again. And I think it's about supporting each other, collaborating. I've done none of this by myself. I've got a big team. I've got friends, colleagues throughout the country and throughout the world who have supported us in doing this, supported me in doing this. Unless we build up the spirit of generating data in our country, we are never going to get forward in our country. This is the primary ciliary dyskinesia guideline, and this exemplifies the common airway. So it's the European Respiratory Society, American Thoracic Society guidelines on PCD, which again, we wrote up. I was fortunate to be representing Asia in this guideline, and we spoke about PCD diagnosis in the developing countries. So that was my mandate in this guideline, which is what I did. And there's a publication which has come out in the ERJ, which you would be very welcome to read. So this is about the mucociliary escalator I started speaking about, which is in the upper airway, which is there in the lower airway. The fact that the upper airway with patients with PCD have chronic rhinosinusitis, they have nasal congestion also the ear, they have glue ear, conductive hearing loss, and in the lower airway they have bronchiectasis and all the symptoms that come with bronchiectasis, and then respiratory failure. It's a rare disease. 50% have situs inversus, and 70% do not see doctors years after they should. So why have I put this slide up? A, because it's the common airway, and second, also because we need to think about these diseases if we are to diagnose them. And then again, skip a couple, and OSA and one airway I think is very important. There's the nasal disease and the pharyngeal collapse, and there is also the COPD and the asthma, which promote diseases like OSA, which also gives a unified upper and lower airway perspective. So that's the goal. I've put up Arjun and me because we have collaborated in trying to do this oration today, and I'm very thankful to all of you for allowing me to speak and listening to me for the last 40 minutes. But Team ENT, Team Pulmonology, working together on one airway for our patient to improve patient care is what is important. So there's one airway, one team, one outcome. The nose and the lungs are not rivals for clinical ownership. They are partners in a disease that deserves one voice. And the voice belongs to all of us, ENT and Pulmonology, speaking together. Thank you very much.
Thank you, Dr. Dhar, for your extensive evidence-based information analysis and recommendation. Now I ask to invite Dr. Arjun Dasgupta. Yes, sir. Please.
রাজার পাশে থাকলে এরকম রাজাকে সিরিয়াসলি আমি ছোটবেলা থেকে চিনি একদম, মানে ছোটবেলা মানে যবে থেকে আমরা একসাথে ডাক্তারিতে পড়তে ঢুকেছি তবে থেকে। সো ইটস বিন এ লাভলি জার্নি। আমরা একসাথে ছিলাম, এক কলেজে ছিলাম, একসাথে বিদেশে গেছি। ও প্রথমে গিয়ে আমার বাড়িতেই উঠেছিল, একসাথে পড়েছি। উই হ্যাভ বিন থ্রু আ লট, মানে ওপর নিচ আমাদের জীবনে অনেক কিছু ডেথস অ্যান্ড আদার থিংস দ্যাট কেম ইন আওয়ার ফ্যামিলি অ্যান্ড উই স্টেড টুগেদার। অ্যান্ড অবভিয়াসলি আই ওয়াজ সো গ্ল্যাড যে রাজা আমার এখানে এসে জয়েন করলো, কারণ উই depend heavily and I have dealt with very difficult patients of Raja, and Raja has dealt with very, very difficult patients of me, and I thank him for that. And probably with the spirit of collaboration, প্রত্যেক টিম ENT আমরা জানি আর কি, ENT with neurosurgery, neurology and pulmonology, we should go forward together. Thank you.
Now I will read the felicitation certificate. Srimati Rashmoni Mukhopadhyay Memorial Oration, organized by the Association of Otolaryngologists of India, West Bengal. Felicitation certificate to Dr. Raja Dhar. We, the members of the Association of Otolaryngologists of India, West Bengal, feel proud to felicitate Dr. Raja Dhar, MBBS Cal, MD Respiratory Medicine, FRCP London, UK, MSc Evidence-Based Medicine, UK, CCT, Respiratory and General Medicine UK, FCCP USA, FICS, Indian Chest Society, Diploma in Palliative Care, Newcastle University, Certificate in Education, TSET University, for delivering the prestigious Srimati Rashmoni Mukhopadhyay Memorial Oration on 25th April 2026 at CMRI, Kolkata. Topic: one airway, the confluence of otolaryngology and the respiratory medicine. Now I request our president to hand over the felicitation.
So I conclude the session here. Thank you all, sir, for coming over here.